Hi, and welcome to this presentation looking at the evidence for coronavirus 19 clinical presentation, investigations, risk factors, and outcomes for the 13th of April 2020. I'm going to talk briefly about the demographic characteristics of patients, their presenting symptoms, the frequency of their comorbidities, their blood test abnormalities, radiology, then moving on to mortality, risk factors, and the emerging evidence around predictive modeling. So most of what we know so far comes from these large epidemiological studies from the data in China. And these have been supported by more detailed individual case cohort studies, either retrospective or prospective cohort studies, almost all of which are also mainly from the Chinese population so far. However, there is emerging data from Italy and the United States, but overall demographic information on the case cohorts is relatively sparse at the moment. These are the headline figures for the outbreak in China and Italy, which are obviously the most advanced cases. So these are the data from the China CDC, 44,500 confirmed cases. They had a roughly even split between males and females, with around 51.4 and 48.6, mainly slightly more males. But in Italy, notably, of their 25,000 confirmed cases till the middle of March, they had nearly 60% male and 41% female. And then median age was 63. The Chinese data didn't publish their median age, but they did publish these age charts. So these are for the epidemic in Wuhan on the left, of Hubei province in the middle, and China overall on the right. So 87% age 30 to 79 with a kind of peak in middle age, and then reduction in older adults, and very, very few people under the age of 30 overall, and particularly under the age of 20. They roughly reported an even male to female ratio, 1.06 to 1, which is not matched by the Italian data so far, which is interesting. I'm just going to talk briefly about this study. This was the first big, well-conducted cohort study of nearly 1,100 patients published in the New England Journal towards the end of February. This basically defined what we understood coronavirus to be as the epidemics are emerging in Italy and in the rest of Europe and the United States. This provided a very, very high level of detail, but it's still an observational study of 1,100 patients, so it has very limited generalizability. And since then, many hundreds of observational cohort studies have been published with various different populations looking at various different aspects of the disease. So what I'm going to do is I'm going to look at the systematic reviews and meta-analyses, mainly of these large groups of patients as they've been emerging. And I'm going to compare it to this original cohort study, which remains the largest one of the Chinese population published. And I've just included this graph on the right just to show the volume of information that comes out of these cohort studies, and how sometimes it's quite difficult to interpret what all of this means in a wider population context. So just looking at the presenting symptoms, these largely come from the meta-analyses conducted of the large number of cases in China. So there's two of these so far, Yang and colleagues from the International Journal of Infection and Cao and colleagues from the Journal of Medical Virology. And then I've just included the Guan study from the New England Journal at the bottom just to see what that looks like. So each of the different studies has a different frequency of most common presenting symptoms. Fever comes out quite highly, 90% in the Yang study, 87% in the Cao study, so it just depends how you add these things together. Cough, relatively common, but only in 2/3 of patients roughly. Difficulty with breathing in about 30 to 40%. The Yang study measured fatigue in half of patients. The Cao study measured myalgia instead, which was in about 1/3 of patients. And just compared that to the Guan study at the bottom, where it's similar, but certainly shortness of breath was less common in their population, and myalgia was less common, for example. And they found that 1/3 of their patients produced sputum, but this wasn't widely aggregated in the meta-analyses. And there's almost no information on presenting symptoms from Italy, the USA, or the UK as yet. This is just another meta-analysis study that I haven't published the results of because it was much smaller, but this is just a nice table of all of the presenting symptoms for each of the underlying studies that they included in their study, which was published at the beginning of March. And what it just shows is that if you look at N in the left, in the middle left column, the variation in the numbers of people in these studies is very, very high. And then if you look at the prevalence of these different symptoms, fever, cough, sore throat, myalgia, sputum, headache, hemoptysis, diarrhea, dyspnea, it's huge variation in what symptoms are being recorded in each of these studies. And it's difficult to know whether this is a difference in recording and data collection, or whether there's actually a difference in clinical symptoms with different clinical syndromes. Because ultimately, you can only measure what you're counting. And if you haven't included some of these symptoms in your data collection, then you're going to miss them altogether. And as you're probably aware, there are some areas emerging of interesting clinical syndromes that aren't captured in these kind of data. So there's been much discussion of GI symptoms overall, particularly diarrhea. And there's been a couple of studies published in the last few weeks that look at these. So there's the Jin study, which is published in Gut with 651 inpatients in China, so another cohort study, and then Chung study in gastroenterology. Just looking at the Jin study first, 11.4% had GI symptoms, mainly nausea, vomiting, and diarrhea. Of those, 23% of these had critical illness compared to 8.1% without, although the statistics on this is very limited. They also found an increased frequency of family clustering associated with GI symptoms, which suggests possible fecal-oral transmission. The Chung study has two components, a cohort of 59 patients in Hong Kong, and then a meta-analysis of 60 other studies with 4,000 patients in it. In their cohort, they found that 25% had GI symptoms, and in the meta-analysis, nearly 18% had GI symptoms with a certainty range of 13.3 to 24.5. Which is possibly a bit higher than Jin's study. They've also contributed my favorite diagram in medical literature to come out of the coronavirus outbreak so far on your left. So in case you are in any doubt, coronavirus in, poo out with coronavirus in it. So looking at these two charts of their meta-analysis, the middle one here just shows the frequency or the prevalence of different GI symptoms. So anorexia, the most common, nausea and vomiting, 10% of patients, diarrhea in about 12.5%, abdominal pain in 10%, and any GI symptom overall, 17.6% in 4,500 patients. And interestingly, on the right, they look at the stool viral positivity rate, which across all of the studies that they included was about 50%. So there's a good chance that actually people might be shedding an infectious in their stool. Similarly, ENT symptoms, this seems to be a big focus of lots of research from Italy, particularly Italian ENT surgeons, where it wasn't such a focus in China. There's two studies, both of which are quite small, a cross-sectional study of 59 hospital inpatients. A third had a taste or smell disorder, 20% had both, 20% prior to admission, and then 13.5% during admission. And then there's this larger cohort of patients from European hospitals. This was a young cohort of patients, which is quite unusual, possibly because the older cohorts had been admitted to ITU and weren't able to participate. 85.6% had a smell disturbance. 12% had this prior to other symptoms. 2/3 at the same time as their other symptoms or afterwards. 90% had taste disorders, and many had ongoing smell and taste disorders once they'd been discharged, and this had no association with comorbidities or prior ENT diagnoses. So looking at comorbidities that people turn up with, there's two big sources of evidence for this so far, the big epidemiological studies from China and the newly published data from the US CDC. So in China, 26% had any comorbidity, hypertension the most common, followed by diabetes, then cardiovascular disease, which in this case excluded hypertension, and then respiratory disease and cancer. The amount of comorbidities was much higher in the US population so far, but it was a small population compared to the whole population who had comorbidities data. So about 38%. 10% with cardiovascular disease, it's unclear whether that included hypertension or not, 11% with diabetes, 10% with respiratory disease, 3% with chronic renal failure. So it looks a bit different than the data from China. However, it depends on the underlying prevalence in the population, which is part of the problem. So this is just a nice example of diabetes, which was a meta-analysis of 12 studies from China and Italy, and a hospital cohort from Italy. So they looked at the prevalence of diabetes in coronavirus patients in China, which was found to be 10.3% where those data were available, versus 10.9% in the population overall and 12.3% in ages 40 to 59. So actually maybe the same or less as in the general population. And in Italy, a smaller population, they found the prevalence to be nearly 9% versus 6% overall in the population, but 11% in ages 55 to 75, which is the cohort most effective in Italy. So you've got to be careful when looking at data like these, not to draw any assumptions until they're compared to population level data as well. So these are the presenting laboratory findings. Again, these are simply the most frequent among COVID positive patients in these studies. So I've included the large Chinese meta-analysis and then some other smaller ones, and then compared it to the Gwen cohort from the New England Journal as well. I think overall, there's just a real range of this. So low lymphocytes was moderately common. This was really focused in on by the Guan study, 83%, but actually in the larger cohorts, it's lower, between 43 and 64. The cow study is probably the largest, but there's some questions about their methods, but 60% nearly. Low white cell count overall was found in between 20 and 30% of patients roughly. But then in both of these larger, certainly in the large meta-analysis, having a high white cell count overall, probably as a result of neutrophilia, was 11%, or nearly 17% in the Rodriguez-Morales study. High CRP in about 60% of people, and a high LDH again, maybe in about 60% of people. The Gwen study also highlighted low platelets as a very frequent finding, and the Rodriguez-Morales study found a high ESR. But again, there's a very, very high amount of variation, and these are just the most frequently reported findings. So again, it depends what you're counting. The radiologists have really gone to town on this and published just an overwhelming volume of papers looking at all of the different radiological findings, some of which we're now very familiar with in hospital. I'm not going to talk about this in too much detail because there's just so many imaging studies. Just looking at chest X-ray changes, these are two, one meta-analysis from Chinese patients, and then another one, Canal and colleagues published in Radiology, which did a nice comparison between chest X-ray and CT findings with 55 serial chest X-rays. In the Rodriguez-Morales study, 73% had bilateral pneumonia, which is quite high, and then about 70% ground glass opacities. I'm going to talk about that again next in a minute or two, but there is a question about whether you can diagnose ground glass opacity from chest X-ray or not, but both of these studies do it, which is interesting. In the Canal study, 70% of baseline chest X-rays were normal, and their changes, the most frequent findings were bilateral changes, but in their study only 50%. 47 had some kind of consolidation. A third, again, ground glass opacity, but whether you can diagnose that from a chest X-ray or not is unclear. 41% were peripheral, 50% in the lower zone, and 3% had a pleural effusion, which is interesting. So there's still very high levels of variation in chest X-ray presentation, which is interesting. There have been two useful large-scale studies of CT scan findings. I'm going to compare on the left a literature review of 5 case series published in Radiology of the CT imaging features, and on the right, just to compare it to the emerging data from Italy, a prospective cohort of 158 patients in Rome. And if you know, ground glass opacities plus minus consolidation and ground glass opacities present at the top of both of these lists. So I've included a little definition of that for the non-radiologists listening to this. A hazy increase in attenuation that appears in a variety of interstitial and alveolar processes with preservation of the bronchial and vascular margins. And so with a definition like that, it sounds like you probably need a CT to be able to see it. So having it on chest X-ray findings is probably not that helpful. So ground glass opacities, if you look at the Chinese data, common multiple lesions, bilateral, posterior, peripheral, all the things that we've seen, and then slightly less common consolidation by itself, crazy paving, air bronchogram, reverse halo sign, pleural effusion. And it doesn't have any cavitation, calcification, or lymphadenopathy, which is interesting. Similarly, with the smaller number of cases in Rome, so multi-lobe involvement, bilateral, posterior, subsegmental vessel enlargement, consolidation, lymphadenopathy, and then reducing down to the bottom there. Both of these papers are worth reading, have good examples. So just to include, there's this really nice paper from Shi and colleagues in the Lancet Infectious Diseases, which if you're interested in the radiology is fab. So this is a 77-year-old man showing the progression of his CT findings from day 5 to day 15 to day 20, and he died 10 days after the scan at the end, just showing how severe it can be on the CT chest. And then similarly, these are the CT scans for a 42-year-old woman from day 3 at the top left there to day 7 to day 11 to day 18 to show how these can improve, and then you can become discharged. And this paper goes into a nice amount of detail about how these scan changes over time. And just to compare it back to the Guan study again, these 1,100 patients, they looked at CT changes from 975 scans that they did in their population, 56.4 showing ground glass opacities, 52% bilateral patch shadowing, which is slightly lower than in the aggregate studies. But they found that nearly 18% had normal CT scans in non-severe disease, and 3% of them, even with severe disease, had roughly normal CT scans, which is really amazing. Fortunately, guidelines have started to be produced. So these are by the Fleischner Thoracic Radiology Society. And their main recommendations, imaging not routinely indicated as a screening test in asymptomatic individuals, not indicated for patients with mild features unless they're at risk of progression. It is indicated with moderate to severe features. It is indicated for patients with evidence of worsening respiratory status, and then some information about resource-constrained environments. Daily chest radiographs are not indicated in stable intubated patients. CT is indicated in patients with functional impairment and or hypoxemia after recovery. And testing is indicated in patients incidentally found to have findings suggestive of COVID-19, and these were done through a kind of consensus method, which is good. So I'm just going to have a quick look at the outcomes and risk factors. There's so much evidence for this, and it's quite all over the place. Aggregating this together is quite difficult. So I'm going to look at mortality first. So the first 2 studies are from China. There's the China CDC data of the 44,600 positive cases. So their case fatality ratio, so this is just the confirmed cases, so numbers of deaths over numbers of cases, was 2.3%. So this is a pretty crude estimate of severity. This increased to 8% in adults aged over 70 to 79, and 15% in those aged over 80 years. They didn't find any deaths in mild or severe cases, only in critical cases. And in critical cases, the case fatality ratio was 49%, which is pretty staggering. The PAN study, which was just recently published this week, has individual level data from 32,500 cases. So it's really, really nice study. So they compared the risk of death in people aged 20 to 39. If you're over 80, your relative risk was 3.6 times higher. And if you are less than 20, it's 0.47. So the older people are really those most at risk of this. In the aggregate study from the Italian population, 25,000 cases, their case fatality ratio was 6.8, so nearly 3 times higher than the Chinese data so far. However, it wasn't evenly split. Their CFR was 8.1% in men and 5% in women. So Italian men are dying at a much greater rate than women. And these ratios are shown throughout all of their data with the different age groups. So 60 to 69, 3.2, 70 to 79, 12%, 80 to 89, nearly 20%, and 90% over 20%. But if you look at the differences between men and women in those numbers down the right-hand side, particularly in the older age groups, so over 90, a third of men die, where it's only 17.8% of women, or 80 to 89, 21% of men, whereas 15% of women. So older Italian men are dying for reasons that aren't clear. And these don't show up in the Chinese data in the same way. So interestingly, just to look at the modeling done on the passengers of the Diamond Princess, where they managed to test everybody. So they found their case fatality ratio to be 2.3% as well, which is the same as the China data, with a range of uncertainty there. They also calculated the infection fatality ratio, which is the number of deaths over the total number of cases, including asymptomatic and false negatives. So you can only really get it from either 100% population or through modeling. And they estimated that to be 1.2% with a range of uncertainty. However, in their over 70s, the case fatality ratio was 18% and the IFR 10%, just showing how at risk older people are. And the CDC COVID response team have recently published some epidemiological estimates for their first 4,200 cases. And their CFR by age group ranged from 1.8 to 3.4%. And so this is just shown in this graph here. So in the top left-hand corner, it shows the hospitalizations, the ICU admissions, and case fatality rates for each of these different cases for the first 2,500 people. So overall, hospitalization a fifth to a third, ICU admission 5 to 10, 12% roughly, and case fatality 1.8 to 3.4. But if you can see, it's just really focused in those older population groups with particularly high case fatality rates once you get above 75-year-olds, and pretty high above 55. And the graph on the right just shows the absolute numbers of hospitalizations, ICU admissions, and deaths in these populations. So actually hospitalizations is common in younger age groups, but you can see the ICU admissions peaking at 65 to 74-year-olds and deaths peaking in the kind of 75 to 85-year-olds there. But these, again, are very emerging new data and only based on frequency. So there's very high levels of uncertainty in these estimates so far. So there have been some estimates of severity published. So in the Chinese data, 81% mild, 13.8% severe, 4.7 critical. The Italian study, 45.1% mild, 24% severe, and 5% critical. So the picture in Italy was of more severe disease, but with a similar amount of critical disease. And they had 13.1% hospitalized and 12% in ICU with a median age of 67, so high ICU use. The American data that's coming out so far, so again, hospitalizations 20 to 30%, which is much higher than the Italian study. And the ICU admission rate 5 to 12%, which is closer to, was somewhere between China and Italy so far, with big differences by age group. So if you're over 65, a third of cases, nearly half hospitalizations, more than half ICU admissions, and 80% of deaths. So it's really a disease of older people. And no ICU admissions or deaths in those under 19 years. So young people appear to be preserved. So I'm going to have a look at how comorbidities might contribute to this. So these are all from Chinese studies. And we're starting to get quite good data on the effect of comorbidities from China. These are, the first one is the epidemiological study, again with the case fatality ratio of 2.3%. However, the morbidity was the mortality was increased with comorbidities. So it was 10.5% if you had cardiovascular disease, 7.3% in diabetes, 6.3% in respiratory disease, 6% in hypertension, and 5.6% for cancer. So between double to 3 times. And then these meta-analyses all looked at different measures of risk, which is much more helpful way of thinking about this, I think, than just these absolute proportions. So Yang and colleagues looked at a meta-analysis including 46,000 patients. So risks of severe disease, the odds ratio was 2.3 times for high blood pressure, 2.5 times nearly for cardiovascular disease, and 3.4 times for respiratory disease. So much higher risk of having severe disease with these. This study by Wang and colleagues in aging, a smaller number of studies, but had a wider range of comorbidities included. So they found COPD was really high, 6, an odds ratio of 6 for severe disease. Stroke, which wasn't calculated in the Yang study, 3.89. Diabetes 2.47, cardiovascular disease for them came in at 2.93, which is roughly the same, and hypertension 2.29, which is roughly the same. They found no association with liver disease, which is interesting. And then a study by Guan in the European Respiratory Journal. This is a cohort study, so retrospective observational study of 1,600 patients. And they used an aggregate endpoint of ICU admission, invasive mechanical ventilation, or death. And they actually found cancer had the highest hazard ratio, 3.5, then COPD, 2.67, then hypertension, which was slightly less, 1.5, and diabetes, 1.59. So it depends what your outcome is. Death, severe disease, or this composite outcome changes your risk. But certainly comorbidities appear to have quite a profound effect. We don't know the answer from Italy yet, but these are the counts based on 1,500 deaths from Italian hospitals. So ischemic heart disease, 28% of deaths, AF in 23% of deaths, heart failure in 16% of deaths, stroke, hypertension in 70% of deaths, really high. Type 2 diabetes in a third, dementia, COPD. One of the things that's most interesting about these is that if you look at the bottom, the number of comorbidities appears to have a huge effect. Multi-comorbidities is a significant risk, with 61% of those who died having 3 comorbidities or more. So that's very important to bear in mind. But these are just counts, and there's no statistical analysis done on these yet. The same data are available on risk aren't available for the USA or the UK as of yet, but I've just pulled up the ICNARC UK critical care audit data just to make a comparison here. So this is up to date as of the very beginning of April or early on in April. So this just shows the admissions to critical care in the chart on the left. And it shows, interestingly, that in the UK, men are being admitted at a much higher rate to critical care than women, and much higher than other viral pneumonia, 2017 to 2019. So this certainly seems to be a disease that gives men critical illness above women. And then if you look at the chart on the right, these are just some comparisons with about 1,700 people with an outcomes, either death or discharge. So discharged alive from critical care here, died in critical care, and then died in critical care compared to other viral pneumonias. So certainly the deaths are really concentrated in those of older age. So if you look across 60 to 69, 56% versus 26.2 in the non-COVID pneumonias, 70% in 70-79 versus a third in non-COVID pneumonias, etc. Similarly, both men and women appear to die more often from this, and men slightly more than women, but probably not to the extent we've seen in the Italian data, although it's unknown. Much higher rates of death with higher BMIs. So if you look at the BMI 30 to 40, 54% died in critical care as opposed to 19% with other viral pneumonia. If you're more frail, require more assistance, then you're much more likely to die of this than compared to other viral pneumonias. And any very severe comorbidities, again, much more likely to die here. But these have not been subject to statistical analysis. So these are just frequencies. So we need larger numbers and some statistical tests to work out what the significance of all of this is. But it's emerging data anyway. Respiratory co-infection has come out quite a lot. There's a very small amount of data on this, so I'm just going to have a look at some of that. So a Wang study, which is in a preprint of 2,745 COVID positive patients. 6% had another respiratory viral pathogen, coronavirus infection, influenza A, rhinovirus or influenza. In an intensive care study, 150 patients, 16% had a respiratory co-infection, although they don't say what any of them are, which is not helpful. The Zing study, 68 patients in Qingdao. Interestingly, 80% of their patients in Qingdao had an immunological response to another respiratory virus, but not so much in Wuhan, which is unexplained. They found flu A, flu B, Mycoplasma legionella. And then there's this unusual study of a retrospective cohort of 60 cases in an infectious diseases unit in the UK. They used a screening tool to evaluate whether they should do a COVID-19 test and then looked at the results. They found 61% had no defined pathogen, 20% had rhinovirus, 15% had non-SARS-MERS coronavirus, 4% had flu A, and there was 1.5% with Mycoplasma, RSV, adenovirus, or metapneumovirus. Unusually, they don't say how many people actually had coronavirus, so I'm not sure how reliable that is, but it gives you an idea of if the people are presenting with COVID symptoms, what other things are around. There are some emerging evidence for predictive lab findings. These are quite detailed studies looking for correlation between lab findings and outcomes. So I'm just going to talk through these as quickly as I can. So there's the Gao study, which compared 28 mild and 15 severe cases. They found that interleukin 6 plus D dimer had good specificity and sensitivity for predicting severity. Q and colleagues looked at 30 patients with severe and non-severe disease, and they found that platelet to lymphocyte ratio was correlated with the length of hospital stay and severity with good sensitivity and specificity. And then Liu and colleagues looked at 61 patients with 26 variables modeled and found the neutrophil to lymphocyte ratio was good at predicting severe illness. I think it's really important to say that you need such a lot of data over a period of time to do these complicated meta-analytic models that it's very difficult to say at this point what might be predictive of either severity or outcome based on these kind of numbers. So this next study by Lagunas Rangel was a meta-analysis of 6 studies, which include 828 patients from China. They similarly found neutrophil to lymphocyte ratios to be predictive of severe cases. and similarly lymphocyte to CRP ratio to some degree. However, this is still 828 patients, which is pretty small. And in this interesting zoo study from the Lancet, they did a very detailed retrospective cohort of 191 patients, and they found that D-dimer was correlated. And I'm going to talk about the study again in a minute or two, because this shows nicely the effects of univariate regression versus multiple regression in determining these things. So this is that study. And what it shows is that on the left here, these are charts of survivors and non-survivors of the 191 people included. So you can see the D-dimer increasing substantially in graph A in the non-survivors versus the survivors. Lymphocyte count is consistently lower. Interleukin-6 is going up there in the red. Similarly, ferritin going up so far, it's off the chart. Cardiac troponin going up significantly, although with these huge confidence intervals. And then the LDH, for example, also there. So if you put these figures into a univariate regression model, high interleukin-6, troponin I, LDH, lymphopenia are all associated with death. However, interestingly, once you stick it in a multiple regression model, the things that they found in the cohort of their patients that were associated with in-hospital death were older age, 10% increase, higher SOFA score, so sequential organ failure assessment, was massively associated with it, 6%, so that's very important. And then interestingly, the only one of the lab tests that was independently associated with it, out with all the rest, was a D-dimer. So that just shows how important it is to get a good multi-regression models in place, because otherwise higher frequencies or increased proportions do not tell you what is independent of everything else. So how do you put all of these factors together? Well, this is a really excellent study that was just published in the BMJ, which I'd really recommend you reading. And it basically highlights the problem of developing predictive models using lots of studies with very small cohorts of patients. So their objective was to review and critically appraise published and preprint reports of prediction models for diagnosing coronavirus disease in patients with suspected infection, prognosis, and then outcomes. And they say that earlier reports suggest that elderly patients, patients with comorbidities, and patients presenting with dyspnea are vulnerable to more severe morbidity and mortality after COVID infection, which is kind of the evidence that I presented here. But what they found was that they identified 3 models that predict hospital admission for pneumonia and other events as proxies for COVID-19 pneumonia, not using COVID-19 populations. They found 18 diagnostic models identified for detecting COVID infection, and 13 of those were machine learning based on CT scans, which the Fleischner Society had suggested probably wasn't a good idea. And they found 10 prognostic models for predicting mortality risk progression to severe disease or length of hospital stay. And the proposed models are poorly reported and at high risk of bias, raising concern that their predictions could be unreliable when applied in daily practice. So in conclusion, until bigger studies with good validation can be developed, predicting risk based on the small amount of data that we have, and particularly the many small cohort studies, is a big problem. And I will keep you updated as the evidence in this domain increases over time, hopefully. So that's it for today. I hope that was helpful, and thank you very much for listening.